Dear colleagues, in this case PCR occurred and I managed the last fragment of the nucleus using IOL as scaffold. Let us see the whole surgery. By this time the main incision 2.8 mm has been made. I usually make the main incision on the steep meridian of the cornea as determined by a corneal topographic reading. Two stab incisions are made on either side of the main incision. These stab incisions are usually 2.5 to 3 clock hours away from the main incision. Now I incise the anterior capsule with a 26 gauge bent cystitome. Now I use a Utata forceps and do capsulorhexis. I press against the anterior lip of the main incision and leakage of viscoelastic substance becomes so minimal that I can complete the rhexis at on go. Now hydrodissection is done. With a 27 gauge cannula, BSS is passed just underneath the anterior capsular rim. We can see that the fluid wave goes from one side to the other side. The nucleus is depressed and the nucleus is rotated. And now is the time to enter into the eye with the tip of the Phaco handpiece. Viscoelastic substance is again injected. I have used HPMC in this case and no other viscoelastic substance. Now this is Portly Catrix 3 Phaco machine from Switzerland. I sculpt a bit, make a small pit, hold the nucleus at a deeper level, and I chop the nucleus into two halves. I rotate the nucleus and chop it at another place. In this case, the Phaco power was 65%. Flow rate was 45 ml per minute and vacuum was 450 mm of mercury. And at this stage, I am not expecting any problem in this case. I am thinking that everything will go fine as it usually goes. But PCR can occur even to the most experienced Phaco surgeon. At this time, I could make out that the antechamber is not stable. It is much more stable in other cases. And my assistant said that she has to change the bottle. So I came out and another bottle was used and see what happens here. As I try to emulsify this last piece, here it is. I catch the posterior capsule and I can see that I have made a small posterior capsular rent. And there is this last fragment remaining. And if I try to emulsify this last fragment, anything can happen. Some pieces, small bits, can go into the vitreous cavity. There can be a lot of post-operative inflammation, a reaction. The patient can experience very disturbing floaters. I tried to make a small posterior capsulorhexis, but I could not see properly, and I failed to do it at this stage. So I inject some more viscoelastic substance and I enlarge the main incision a little bit and inject a multi-piece intraocular lens, foldable intraocular lens in the sulcus. This is a sensor multi-piece, 3-piece intraocular lens from Abbott Medical Optics. In this case, the leading haptic has gone into the sulcus, that is just over the anterior capsular rim, and I try to place the trailing haptic in the sulcus with a McPherson's forceps, but it comes out and rests over the iris. I inject some viscoelastic substance and now I go into the anterior chamber and emulsify this last fragment, and I am sure nothing will happen. It will not go into the vitreous cavity. I have lot of respect to Dr. Amar Agarwal, who first described this, that intraocular lens can be used as an scaffold, as a platform over which last few fragments can be safely emulsified without causing any endothelial damage. Now I remove first the small nuclear solid fragments and then I try to remove the cortical matter. Now it is going to be cumbersome to remove the cortical matter, but I found that it is not that difficult. When the PC rent is small, it's not difficult to remove this cortical matter. So I have removed some cortical matter from 4 o'clock to 5 o'clock. Now I go through the side port, which is at around 1:30 o'clock, and remove the cortical matter which is there at 8 o'clock, 9 o'clock, 7 o'clock, in that region. Now I go through the side port at 8 o'clock and remove the cortical matter which is there at 11 o'clock, 12 o'clock. But I can't remove the cortical matter which is there at around 1 o'clock to 3 o'clock. So here it is. I go through the main incision, go behind the IOL, and I pull this cortical matter and it comes very easily. Now I go to the other side and remove the cortical matter from 7 o'clock. Still at 6 o'clock some more cortical fibers are there, and that's it. I have removed the cortical matter. At this stage I could have complete the surgery and leave whatever little bit of cortical matter is there and whatever little bit of viscoelastic substance is there in the anterior vitreous. But I wanted to do some more cleaning. So what I am doing is I am going behind the IOL and I am removing this little bit of cortical matter and I am aspirating some viscoelastic substance through this small rent. And now I dial the lens and place it nicely over the anterior capsular rim. That's it. Now I try to do some more. I could see that some vitreous strands are there at around 5:30 o'clock, and I wanted to remove that. And now before coming out, I inject a big air bubble. Here it is. The air bubble is injected by my assistant, and I remove the irrigating probe. Now I inject moxifloxacin. Now I hydrate the side ports, form the antechamber nicely, and conclude the case. Conclusion. In this case, I could have left without doing vitrectomy just after removing the cortical matter. But I wanted to do vitrectomy. In that process, I enlarged the PC rent. Anyway, it was, I think, well managed. And here it is. We can see the posterior capsular rent like U-shaped in the higher magnification. No vitreous strands coming to any side port. And here it is. I conclude this surgery. Hope this video will be helpful in your practice. Thank you very much for your attention.